Hello everyone, and welcome back to our final lecture of the semester. So this is our chapter 16 lecture for module 3. And so today we're going to be talking about some biomedical therapies. So far in this chapter we went through some of kind of the basic barriers to treatment and the different types of people who might administer treatment. We've talked a bit about some of the talk therapies, the psychotherapies that involve, working with clients to help change their thought patterns and their behaviors. And now we're going to get into some of the more medical ways or biological methods of helping people control their mental illness. So the biomedical approach to treating psychological disorders involves using drugs, surgery, or other medical procedures to alter the functioning of the central nervous system. So you might remember when we talked about the consciousness chapter last semester, we had a section on psychoactive drugs, and some of the drugs we talked about there will actually be contained in this section as well, because some of them can be very effective in helping alleviate some of the symptoms of mental illness. So psychopharmacotherapy is the use of drugs to manage or reduce client symptoms. It is by far the most frequently used biomedical option. So there are other options such as electroconvulsive therapy and some treatments that kind of focus on intervening in the brain, which we'll get into a little later, but definitely the most common method is using medication to manage the symptoms of mental illness. And this is something that even as clinical psychologists, we're not the ones that are actually prescribing the medication, but we actually do still take courses in psychopharmacology and learning about the different medications that might be used to treat mental illness, because it's important for us to know when we're treating people with psychotherapy how that might interact or intersect with some of the medical options that they're being provided. So it is often used in conjunction with some form of psychological therapy. And there are other options, as I mentioned, such as surgery or electroconvulsive therapy, which are typically only used in cases where no other available treatments have succeeded. So first we'll start by talking about some of the drug treatments. So psychotropic drugs are medications designed to alter psychological functioning. The drug approaches to treating psychological disorder were first typically used in institutional and clinical settings. So you might remember when I talked about the deinstitutionalization, a lot of that, the ability to kind of release people back into society from these institutions, was due to the fact that we found some effective medications that could really help treat and manage some of the symptoms of mental illness. So at first they were generally targeting the more severe cases, but in recent decades they had become more mainstream practice. It's very common for someone these days to go to even their family doctor, their family physician, and say, hey, I've been struggling with whatever area, and sometimes, even just a general physician, a GP, will prescribe, antidepressants or anti-anxiety medications. Psychotropic drugs are designed to cross the blood-brain barrier, which is a network of tightly packed cells that only allow specific types of substances to move from the bloodstream to the brain in order to protect delicate brain cells against harmful infections and other substances. So there is kind of this barrier that helps protect your brain, but these drugs are specifically formulated to be able to cross that barrier and in order to take effect. So once they cross this barrier, they affect either one or more neurotransmitters within the brain. And so we'll talk about some of the more common neurotransmitters that are targeted. And a lot of these words are going to be familiar to you based on our chapters in biological psychology and in consciousness, where we talked about the mood-altering drugs. So antidepressant drugs are medications designed to reduce symptoms of depression. Despite the fact that obviously depression is in the name, they are also the most common type of drug used to help with anxiety as well. So for something like generalized anxiety disorder, where it's kind of a more consistent worry across time, an antidepressant would actually be the drug of choice rather than an anti-anxiety medication, because as we'll see on the next slide when we start talking about anti-anxiety medication, those are actually usually only prescribed for short term. Because they do have high rates of potential addiction and dependence and things like that, and misuse. So antidepressant drugs are most commonly used to treat depression as well as some anxiety disorders. The first type of antidepressants to be developed were monoamine oxidase inhibitors, or MAOIs. And so these were drugs that work by deactivating monoamine oxidase, or MAO, which is an enzyme that breaks down serotonin, dopamine, and norepinephrine at the synaptic clefts of the nerve cells. So they're now used less frequently than others because unfortunately they did come with a lot of dangerous side effects, especially when they interact with other medications and certain types of foods. So for example, things like aged cheese, smoked meat and alcohol and other substances have been known to kind of create some really negative side effects when used in conjunction with MAOIs. So they were the first type to develop, but they aren't used as often anymore. You will notice, however, that basically by deactivating that MAO, they were able to stop that enzyme from breaking down serotonin, dopamine, and norepinephrine, so they effectively help to increase serotonin, dopamine, and norepinephrine that was available in the synapse. And you will see that that kind of lines up with the purpose of the other types of drugs as well, but they just kind of have a slightly different method for doing so. So then we have the tricyclic antidepressants, which were another early type of antidepressant, and they appear to work by blocking the reuptake of serotonin and norepinephrine. So like I said, if you have an MAOI, it's going to stop the breakdown of serotonin and norepinephrine, which is going to in turn increase the amount of serotonin and norepinephrine available for the neurons to use. Tricyclic antidepressants are just going to stop it from being kind of sucked back up into the presynaptic neuron. So they're working by different mechanisms, but they're both serving to increase the amount of those neurotransmitters available in the synapse. And then finally, we have selective serotonin reuptake inhibitors, more commonly known as SSRIs, and these are probably the most popular type of antidepressant prescribed today. They are a class of antidepressant drugs that block the reuptake of serotonin, and they possibly take effect by reducing overall arousal or decreasing activation in the amygdala. So SSRIs are known for kind of having the least potential negative side effects of these three types. Even the tricyclic antidepressants, unfortunately, also came with some bad side effects such as weight gain and sexual dysfunction. So the SSRIs so far have been shown to have some of the least severe side effects, and they do work specifically on serotonin, in blocking serotonin uptake, but there are also SNRIs as well, which are essentially selective norepinephrine reuptake inhibitors, which kind of act in the same way but on norepinephrine rather than on serotonin. So there are a bunch of different types, but these are kind of the three main that we focus on, and definitely of these three, the SSRIs I would say are the most likely to be prescribed today. Of course, it is important to note that all of these medications work in different ways for different people. So if you've tried one antidepressant and it didn't work for you, that doesn't necessarily mean that another one wouldn't. A lot of the time it will take patients trying multiple different types of antidepressants and maybe even combinations before they find the one that really works for them. So here's a little slide that kind of shows some of the antidepressant effects at the synapse. So like I said, with the MAOIs here, they block the activity of that enzyme that breaks down those key neurotransmitters, whereas with the tricyclic and the SSRIs, they basically just block those neurotransmitters from being kind of sucked back up, or that reuptake into the presynaptic neuron. So in both cases, they're creating more potential availability of these neurotransmitters in the synapse. So they're all acting to kind of increase the effect that those neurotransmitters can have, just in slightly different ways. I want to talk to you briefly about St. John's wort. It's not a chemical medical treatment. It is actually a herbal treatment that can be found in many health food stores and pharmacies. And I want to bring it up here because it is something that a lot of people do kind of run into if they're searching for different remedies for depression, and it is something that can have some effect at times, but also can have some dangerous side effects. So I wanted to kind of bring it up and just give you a bit of information on it. So it does appear to influence several of the neurotransmitter systems that are altered by traditional antidepressant medications, including serotonin and epinephrine. Research using animal participants has shown St. John's wort to reduce a number of behaviors linked with depression and anxiety, and a recent meta-analysis of its effects on human participants found that it did lead to reduced levels of depression when compared to placebos. So in some cases, it appeared that ingesting this herbal treatment could be just as effective as antidepressants. However, you do have to be very careful when using any herbal remedies, and this one in particular, because it's not standardized or carefully regulated by government agencies, and it may interact negatively with other drugs. So there are a lot of potential interactions to worry about. It can decrease the effectiveness of other types of medication as well. So, you know, I'm not telling you that it's not something that could be helpful to use in certain cases, but you do always have to use a little more caution when you're dealing with these remedies that aren't really kind of standardized and controlled, because you never know exactly what you might be getting. So now we're going to talk about mood stabilizers briefly. And I apologize, I know I said a minute ago we were going to go on to anti-anxiety. We'll get to that. But the mood stabilizers are kind of their own class of drugs, and they're used to prevent or reduce the severity of mood swings experienced by people with bipolar disorder. So unfortunately, the typical antidepressants that we use, especially things like SSRIs, they may not be effective in cases of bipolar. Honestly, and this is a rare side effect, but in some cases, if you're increasing that level of serotonin too much by using SSRIs or other drugs, it can actually contribute to the onset of manic episodes, because they're kind of in a way seen to be almost the opposite of the depressive stage. So one of the first mood stabilizers to be prescribed regularly in psychiatry is lithium carbonate. So you've probably heard of lithium before. It was from the 1950s to 1980s the standard drug treatment for depression and bipolar disorder. It can be very effective at times, but it can also be really toxic to the kidneys and the endocrine system. And so today doctors generally prefer to prescribe other drugs to treat bipolar disorder, such as some anticonvulsant medications or antipsychotic medications. So unfortunately, what we did see with lithium is it also has a very small, what they call the therapeutic window. And so therapeutic window is kind of how much of the drug you need for it to be able to take effect. And with lithium, it was very hard to control whether you were getting enough to have an effect, but not too much that it would create toxicity. So it was very hard to kind of strike that balance with lithium as well. So while it was for a very long time kind of the standard treatment, it's not used as often today as it would have been in the past. Now we get to our anti-anxiety drugs. They're often referred to as tranquilizers, and you'll definitely notice some of the drugs here were listed in the depressant section in that psychoactive drugs review that we did in the chapter on consciousness. So essentially these drugs affect the activity of gamma-aminobutyric acid, which is kind of the primary inhibitory neurotransmitter that reduces neural activity in the brain. So these drugs are prescribed to alleviate nervousness and tension and to prevent and reduce panic attacks. So it's not something, like I said, that you would typically use as a long-term solution. Typically these drugs are kind of prescribed for use as required rather than something that you take kind of every single day. But they can be quite effective, especially if somebody suffers from panic disorder. They can use these drugs to kind of help them alleviate that kind of onset of the really sudden, intense panic that accompanies panic disorder. So these drugs appear to temporarily alter the structure of GABA receptors, and their effects are relatively short-lived. So they don't last for a very long time, but they can be very effective very quickly in certain circumstances when they're needed. And anti-anxiety drugs such as lorazepam, clonazepam, diazepam, and alprazolam, they all have the am at the end. Some of the more common names that you might know would be like Ativan, Klonopin, Valium, and Xanax. And unfortunately, these drugs, which are kind of all owing to the class benzodiazepines, they can have serious side effects and come with a risk of abuse and withdrawal, so their prescription is regulated. So a lot of the time, if you go to like a walk-in clinic, you'll see a sign on the wall that says there are certain types of medications that walk-in doctors can't prescribe, and one of them tends to be benzodiazepines for that reason, because they do unfortunately come with a high potential for abuse and withdrawal. And then we have our antipsychotic drugs. So antipsychotic drugs are generally used to treat symptoms of psychosis, which includes delusions, hallucinations, and severely disturbed or disorganized thought patterns. So these drugs are the common treatment for schizophrenia, and they are sometimes prescribed for people with severe mood disorders as well. So we just mentioned on the mood stabilizer slide that sometimes we will now use antipsychotics in the treatment of bipolar disorder. The first generation was designed to block dopamine receptors, so kind of decrease the activation of dopamine within the brain, but they did come with a lot of really severe side effects, including something called tardive dyskinesia, which was a movement disorder involving involuntary movements and facial tics. So they could lead to some really severe side effects at times. Newer antipsychotics are referred to as atypical antipsychotics. These are less likely to produce the side effects, including those movement disorders such as tardive dyskinesia, that commonly occur with first-generation antipsychotics, but they can still have some risks. So for example, sometimes they can compromise the immune system in some ways and kind of affect white blood cell production and that type of thing, but overall they are kind of considered one of the primary mechanisms for treating psychosis, because unfortunately, as you may kind of recall from the last chapter, it is really hard at times to treat the symptoms of psychosis through other means. So sometimes drug therapy is the most effective form of treatment. This is something that I found very interesting. Your textbook gets into it a little bit, and so I wanted to kind of discuss it here. It essentially, I've heard a lot lately, especially in recent years, about the potential for the use of some hallucinogens and other types of drugs to help treat psychological disorders. So for example, I've heard of people using LSD, acid, in small amounts, kind of microdosing, and also psilocybin, so kind of what you would call magic mushrooms, has also been proven in some cases to be effective in small doses to help alleviate symptoms of certain psychological disorders. And so your textbook doesn't really talk about those, but it does bring up the case for using MDMA for PTSD. And so MDMA, if you don't know, is actually kind of the active component in the drug ecstasy. So it is something that a lot of the time is considered more of a street drug. And we have actually seen that some therapists are using it to try to help treat symptoms of severe PTSD, and in some cases it has been shown to potentially be beneficial. So essentially these treatment programs would have several components. So first you're going to have therapy sessions where the goal is for the therapist to kind of provide psychoeducation on MDMA, what it is and what its potential uses might be. Then you're going to have one or more day-long sessions in which the therapist spends the entire day with the patient. So it's non-directive, they're not telling them what to do, they just kind of follow them and almost supervise them in a way. And so this can kind of help to break down some of those social barriers and strengthen the alliance between the therapist and the client. It's important to note that the doses of MDMA that are given in these circumstances are going to be a very pure dose. So a lot of the time what you'll find in kind of street drugs might not be as pure, it might be mixed with other substances, but the MDMA used for this purpose is going to be a very pure chemical. And then finally, after that experience, so whether there's one or multiple day-long sessions in which the drug is used, there are an additional kind of offering of non-drug related sessions in which the therapist discusses the experience while on drugs with the patient. Sorry, I had to pause there for a second. I had a bit of a coughing fit, but yeah, so basically you'd have the therapy sessions, then you'd have the drug exposure, and then you'd have multiple non-drug sessions in which you're going to talk to the client about their experience while on the drug and maybe some realizations, revelations they might have come to, and overall it just does help a lot of kind of the more severe cases of PTSD. It helps the patient kind of open up to the therapist and really strengthen that alliance and that bond. So a study of 20 patients with PTSD who had not responded to previous treatment did show incredible promise for the use of MDMA. So 83% in the MDMA group no longer met the criteria for PTSD after treatment, whereas the other group, the control group, was given a placebo drug, so it wasn't an active component during the drug exposure days sessions, and only 25% of that group showed improvement. So it did seem that a much higher amount of the MDMA group showed significant improvement and no longer met the criteria for PTSD after that treatment. So it does seem promising, but there are of course some issues. So there's always dangers associated with both short and long-term drug use. We're not 100% sure on what some of the long-term effects might be for therapy such as this. And of course there's always a potential whenever you're using drugs that there may be some kind of addiction form. And so, you know, obviously with a lot of the drugs that we use, prescription drugs we use medically, they don't really have that great of a risk of dependency, but with something like MDMA, because it is something that's commonly used as a street drug and we know that people can kind of become addicted to those types of drugs, that risk might be increased in this situation. So overall, it's really interesting. It's a new area of research, and I'm excited, honestly, to see what comes out of this type of research and the research with LSD and psilocybin and how those drugs could potentially be useful to help treat psychological disorders. So in terms of evaluating our drug therapies, people commonly believe that drugs are designed to target the root physical causes of the psychological disorder and should therefore be more effective than psychological therapies, but honestly that belief is not warranted. In many cases, drugs are not more effective than psychological therapies. So for example, with antidepressants, we see that 50 to 60% of people who are given antidepressants will improve within a few months, improve their symptoms, versus 30% of placebo actually improve, which is still a pretty high number, improving without any active ingredient. And we also see that approximately 50 to 60% would improve with just therapy alone. So it's not necessarily true that drug treatment for psychological disorder is more effective. And in some cases, it does seem that, and I'm getting into this in the second point here, that the effects are more long-lasting. So for example, with anxiety disorders, psychological treatments such as CBT are generally the most effective treatment. The effects are longer lasting because, of course, if you're treating somebody with a medication, that can be great. It can really alleviate symptoms, but there's always the chance that once they stop taking that medication, those symptoms are going to return. Whereas if you're able to actually teach clients better strategies for coping, that can be something that they can kind of carry forward with them and use in a lot of different circumstances. And so it can help those effects be kind of more long-lasting over time. In many situations, a combination of treatment approaches may work best. So depression, anxiety disorders, and even schizophrenia have all been shown to kind of have significant improvement when drug therapy is used in conjunction with psychotherapy. And even disorders that are generally viewed as predominantly biological are better understood from a biopsychosocial perspective. So like I said, even something like schizophrenia, we do know that antipsychotic medication has been really useful in treating a lot of the positive symptoms of schizophrenia. And remember, by positive, I mean the symptoms that are there that aren't usually there. I'm not saying that they're good symptoms, but we do see drug treatments are really effective in treating some of those symptoms, but we also see that certain types of psychotherapy can be really helpful in alleviating some of the symptoms of schizophrenia as well. So definitely overall, we should be taking the time to kind of consider things from that biopsychosocial perspective, which takes into account the biological, the psychological, and the social factors that might be influencing the onset and contributing to the perpetuation of these disorders. So now we're going to talk briefly about some technological and surgical methods. Again, these are less commonly used than some of the drug therapies that we just discussed. I'm sure you've all heard of the frontal lobotomy, which is surgically severing the connections between different regions of the brain. So to give you a bit of background, a bit of history, a Portuguese surgeon named Antonio Manes developed a technique known as the leucotomy, which involves surgical destruction of brain tissue in the prefrontal cortex. And then we had an American surgeon named Dr. Walter Freeman who took this technique and popularized it, naming his version the lobotomy. So that lobotomy is kind of what you would have heard of and probably seen in movies and TV shows. It's not obviously always super accurately portrayed, but it was a very damaging technique that didn't really lead to a lot of positive outcomes in some cases. So a lot of what the media says about it is true. So by the 1950s, the popularity of the frontal lobotomy was dwindling rapidly due to its inconsistent and often negative results. Sometimes it actually would help the patient, but it might lead them to kind of lose a lot of their emotional and cognitive capabilities. So it's kind of like, you're taking away the negatives, but you're also taking away a lot of the positives. But nonetheless, despite the fact that, there were a lot of inconsistent and negative results with frontal lobotomies, the basic practice of therapeutically destroying brain tissue survives to this day. Although in this case, it is much more refined and precise. So you may have heard of the ice pick lobotomy. We're not doing that kind of thing today. Today, when we're kind of going in, we'd be surgically destroying very specific brain areas or altering very specific areas because we have the tools and techniques that allow us to be much more precise at this point. So focal lesions are small areas of brain tissue that are surgically destroyed. They're only used in very severe cases when all other treatment has failed. So as with most of these surgical techniques, we really try not to use them if at all possible, but unfortunately, there are some cases of disorders like depression that are just so severe that nothing else works. And in that case, we can target very specific areas of the brain for intervention. So one example of a focal lesion is known as the anterior cingulotomy, which targets a cluster of brain cells to help treat severe depression and anxiety disorders. It actually has no more risks or side effects than do many of the drugs used to treat these disorders. So even though people might think of it as really scary and they probably have images in their mind of things like those frontal lobotomies and, the old insane asylums, for lack of a better word, that you see in horror movies, it's not what we're doing these days when we talk about focal lesions for treatment. Then you have electroconvulsive therapy, known as ECT, which involves passing an electrical current through the brain in order to induce a temporary seizure. It was introduced in the 1930s, but over the years, techniques have improved dramatically. So it maybe wasn't as safe when it was first performed, but they definitely have really refined that procedure, and it is still used in some cases, again, when it's such a severe form of something like depression or maybe OCD, bipolar, and in those cases it can be really effective. So for example, if you're interested in reading, this is actually an amazing book that I would recommend for anyone to read. There's a book called Undercurrents by a psychologist named Dr. Martha Manning, and we had to read it actually in my undergraduate abnormal psychology course, and it's essentially a first-person account of this psychologist kind of journey with her own depression. So she's a clinical psychologist who was in the midst of treating patients and working, and she ends up kind of descending into the depths of depression herself. And, you know, she's starting to notice, you know, how she's exhibiting more of the symptoms than some of her clients are at times, you know, when she's in her treatment sessions. And her depression does become so severe that she does have to undergo electroconvulsive therapy towards the end of the book. So it's essentially kind of like a series of journal entries. It's a really interesting read, and it's something that really honestly inspired me because, you know, I know that myself, as many of us have struggled with mental health issues at times. And at times, you know, it might make you question if you're able to do certain things, have certain careers, help people in whatever way. And to read that story of an actual clinical psychologist who has been there and back again was really, really inspiring for me. And it really kind of inspired my own journey into clinical psychology. So if clinical psychology is something that interests you, definitely check out that book. Again, it's called Undercurrents, and it's by Dr. Martha Manning. So finally, we're going to bring up just a couple other techniques and before we end our chapter and subsequently end our course. So repetitive transcranial magnetic stimulation, or RTMS, is a therapeutic technique in which a focal area of the brain is exposed to a powerful magnetic field across several different treatment sessions. So you might remember talking a bit about TMS back in the biological psychology chapter. We did talk about it briefly when we were talking about the brain interventions. And so they have actually found that certain types of TMS can be used as a therapeutic technique for mental illness. And so essentially the magnetic field can either stimulate or inhibit activity in particular brain areas, such as the left prefrontal cortex. So it's essentially kind of a less permanent type of therapy in terms of, you know, some of the focal lesions were actually destroying areas of the brain, but in this one we're just kind of stimulating or inhibiting certain areas. So it's pretty much reversible, or it doesn't really have any long-lasting effects. RTMS does not take effect immediately. The treatment typically involves between 10 to 25 sessions with follow-up appointments every few months. It definitely has a number of advantages over other treatments. So you don't need anesthesia, you don't see seizures or cognitive impairments that can occur in certain other types of biological treatment, and it may hold considerable promise for reducing symptoms of disorders such as depression and schizophrenia. So it is a newer technique. We don't know a ton about it yet, but it has definitely been showing a lot of promise in certain cases. And finally, we are going to talk briefly about deep brain stimulation. So this technique involves electrically stimulating specific areas of the brain. So you're actually inserting a thin electrode-tipped wire into the brain and carefully routing it to targeted brain regions. So instead of using a magnetic field, which isn't actually kind of invasive and going into the brain, this technique is actually going to involve kind of routing this wire into the brain so it can reach that targeted area. Unlike many drug and other treatments discussed, DBS does produce instantaneous results and seems to work for even severe cases of depression that have not responded to any other treatments, and it has also been shown to help with disorders such as OCD. However, this technique does not come without risk. As you can imagine, inserting anything into the brain would have at least some amount of risk. So for example, sometimes it can cause internal bleeding or infection. Also, some other kind of odd side effects that have been exhibited are things like spontaneous laughter or spontaneous penile erection. And unfortunately, at times it can worsen some symptoms of depression or even cause aggressive symptoms. So it's not something that, you know, we're going to use without considering other alternatives, but it definitely has been shown useful in some cases and does work with some severe forms of disorders that haven't responded to other treatment. So there are many other techniques still in development, as you could probably imagine. A lot of this stuff, people are kind of improving on daily, and so there are more and more techniques coming out, and it's a really promising area of research. Innovations in gene therapies, neuroimaging, neurostimulators, and computer science are sure to provide patients with a number of high-quality treatment options. So in conclusion for this chapter, I really hope you enjoyed learning about the different therapies, and I really hope you enjoyed learning about the different disorders in the last chapter. As you know, these things are kind of my baby when it comes to the study and research within psychology, so hopefully I made it at least somewhat interesting for you. If you have any questions, feel free to reach out to me. I'll try to answer them as best I can. But to conclude, the future of psychology is exciting. So I really appreciate you, taking the time to take this course with me. And for those of you who have stuck with me since September, I hope you learned a lot and you had a really good experience. And honestly, I just wished you all the best, in your future endeavors. Again, if you ever have any questions or comments, you have my BU email. I'll also drop my Memorial University email on our page before we end for the semester, because I probably won't have access to the BU email after this year. But if you ever need me for whatever reason, feel free to reach out and I'll try to get back to you as quickly as possible. Thanks for tuning in. I hope you enjoyed this lecture, and I will not talk to you in the last one, but hopefully I'll see you all in our review session, which I believe is scheduled for Friday of next week. So that'll be kind of the end of the line in terms of our time together. Take care.